All right, so let's jump right in. Every diagnosis is kind of like a medical detective story, right? Today, we're on the case of a really interesting one, a benign tumor called the spindle cell and pleomorphic lipoma. And trust me, this thing is a master of disguise. But if we follow the clues, we can totally crack this case.
So how does this whole story usually kick off? Well, it almost always starts the same way. You've got a patient, typically a middle-aged to older guy, who comes in with this slow-growing lump that's completely painless. And 9 times out of 10, it's going to be on the back of his neck, his upper back, or maybe his shoulders. Seems simple enough, right? But believe me, this is just the very first page of our little mystery.
Okay, so first up in our investigation, let's look at the classic case, the clinical profile. Who gets this thing, and where does it pop up? The clues here, they're actually super specific.
And get this, the location clue is, wow, it's got some serious statistical power behind it. A whopping 80% of these tumors show up in one specific zone they call the Cape region. We're talking the back of the neck, the upper back, and the shoulders. That's such a strong clue, it becomes our first major piece of evidence.
So we've got our clinical picture. Now the investigation takes a turn. We're moving from the clinic to the pathology lab. And this is where the real detective work begins, because the make-or-break clues are all hidden down at the microscopic level.
To be sure about the diagnosis, a pathologist is on the lookout for what's called a classic histologic triad. Just think of it like finding 3 key fingerprints left at the crime scene. If we find all 3, oh yeah, we are getting very warm.
Okay, so fingerprint number 1 is the background. At its heart, this is a lipoma, which just means it's made of fat. So, what we expect to see is a bunch of these mature, totally normal-looking fat cells, or adipocytes. They're basically the canvas that the other clues are painted on.
Next up, our second clue is all about structure. You'll see these thick, kind of bright pink, ropey-looking bundles of collagen all woven in between the fat cells. They give the tumor its unique feel, and honestly, they're a super distinctive feature.
And finally, we get to the third and, you could argue, the most important clue, the spindle cells. Now, pathologists describe them as bland, which is a funny word, but it just means they all look the same, really uniform, and totally non-threatening. There's just no sign of anything aggressive. So they're our main suspect, but they look completely harmless.
But just when we think we've got this all figured out, we've got our triad, we've identified our suspect, the case takes a major twist. Turns out, our tumor has a whole wardrobe of disguises. It doesn't always play by the rules.
And this is a really crucial point. For a while, we thought spindle cell lipoma and this other thing, pleomorphic lipoma, were 2 totally separate diseases. But we know now that they're not. They're just different faces, different morphologic variants of the exact same tumor. It's all one thing, just with a whole spectrum of ways it can look.
And this slide just illustrates that spectrum perfectly. Check it out. On the left, that's the classic look, right? With those simple, bland spindle cells we talked about. But then look at the right. That's the pleomorphic variant. And the defining feature here are these wild-looking, multinucleated giant cells. The nuclei arrange themselves kind of like the petals of a flower. How cool is that? They're called floret cells, and they are a dead giveaway for this particular disguise.
And oh, the disguises do not stop there. Sometimes the tumor is fat poor, so it has barely any fat, and it can look like a totally different kind of fibrous tumor. Other times, it's got this watery, goopy, myxoid background that can get confused with some pretty nasty sarcomas. It can even have spaces that look like blood vessels, or, and this is super rare, bits of cartilage or even bone. You can see how any of these could send a pathologist down the completely wrong path.
Okay, so this brings us to what is, without a doubt, the most critical part of this whole investigation. When you see all these weird appearances, especially those freaky-looking floret cells, the #1 job, the most important thing, is to prove this thing is benign. You have to be sure it's not a dangerous, malignant mimic, like a sarcoma. The stakes here are, well, they're incredibly high.
And that's the million-dollar question in our case, isn't it? When your main suspect keeps changing its disguise, how can you be absolutely 100% sure of its true, non-threatening identity?
Well, the answer is kind of cool. It's not just about what you see, but what you don't see. To make that definitive benign call, you need to see a strict absence of any red flags. I mean, the tumor can't be aggressively invading other tissue, it can't have any of those truly nasty, malignant-looking cells, and there shouldn't be any signs of cells dying off or dividing like crazy. In this case, the absence of evidence is the evidence. It's evidence that it's benign.
But to be even more certain, we bring in the big guns. We head to the forensics lab of pathology, immunohistochemistry, or IHC. This is where we use these special stains that light up specific proteins. So we're looking for a positive ID, right? We want to see strong staining for a protein called CD34. And, this is super important, a loss of the RB1 protein. At the very same time, we run an exclusion panel to make double sure that all the proteins linked to its evil twins, the malignant mimics, are totally negative.
This chart, this matrix, it shows you exactly how this process of elimination works. Look at our suspect, spindle cell lipoma. It's got a totally unique fingerprint, positive for CD34, but RB1 is lost. Now let's look down the list of other suspects. Atypical lipomatous tumor, that's a low-grade cancer, and it's going to be positive for MDM2. What about solitary fibrous tumor? That one's positive for STAT6. So by checking all these markers, we can just cross the other suspects off the list one by one until only our guy remains.
But wait, there's more. We have one final, absolutely definitive piece of evidence that just locks this case shut. We're going beyond what we can see with stains and scopes. We're going right down to the genetic code of the tumor itself.
And here it is, the smoking gun. Remember how that RB1 protein was missing on our forensic stain? Well, the reason for that is because the actual gene that makes it, the RB1 gene, is physically deleted from chromosome 13 in these tumor cells. This genetic signature isn't just a clue, it's the root cause. It is the ultimate, final confirmation of this tumor's identity.
And you're not going to believe this, but just when you think the case is 100% closed, there's one last little twist. It turns out there are other tumors that look almost identical under the microscope and even have the same RB1 gene deletion. So how in the world do you tell them apart? We have to go all the way back to our very first clue. Location: spindle cell lipoma. That's our Cape region tumor on the back and neck. Its identical cousins, they show up almost exclusively in completely different parts of the body, like the vulvovaginal and inguinoscrotal areas. See? Location, location, location. It's everything.
So, let's put this all together into a unified diagnostic algorithm. This is how all the puzzle pieces fit. Step 1, you assess the clinical presentation. You've got the guy with the lump on his back. Step 2, you evaluate what it looks like under the microscope, that classic triad. Step 3, you do that critical malignancy safety check. And finally, Step 4, you run the special IHC panel for final confirmation, getting you that protein and genetic fingerprint. It's a beautiful, logical process.
And there you have it. Case closed. A truly confident diagnosis isn't about just one clue. It's about the perfect alignment of all the evidence. Where it is on the body, what it looks like through the microscope, and what its unique genetic signature is. When all those things line up, you know you've got your answer.
It really makes you think, doesn't it? What starts as a simple, painless lump on someone's back ends up having this incredibly complex and fascinating detective story behind it. It just begs the question, what other common, seemingly simple diagnoses are out there hiding their own intricate mysteries, just waiting to be solved?